So we are starting our critical care and nursing process of the intrapartum client. There are some theories on the onset of labor. Initiation of labor comes from an interplay of factors, including distension of the uterus, which actually causes irritability and contractility and the hormonal influence. And you can see below here the hormones again come to play. Increase in estrogen, decrease in progesterone. There's an increase in oxytocin, which causes contractions and also cause cervical ripening, which is the effacement, which is the thinning and the shortening of the cervix. Then we have an increase in prostaglandins, which is a smooth muscle contractility and a very potent vasodilator. Then another theory on the onset of labor is uterine distension. It causes cervical pressure, irritability, and contractility. Then there's a decrease in relaxin, which, remember we said in antepartum lecture, we're going to see relaxin again. We're going to see all these hormones again. Relaxin is one of them. It relaxes women's intervertebral joints. Then there's an increase in fetal cortisol, and of course, this is for fetal lung maturity. We talk about the 4 Ps. It breaks it down. The 4 Ps being the passage, being the passenger, the powers, okay, and the psychological component. So those are your 4 Ps. We're going to talk about the first piece when we talk about this intrapartum lecture. First one is passage. Okay, passage is all about the pelvis, or this maternal pelvis and soft tissue that this baby must pass through. So the true pelvis, we talk about the pelvic inlet, which is the upper border. I want to do the different types of pelvises. We talk about the pelvic inlet, we talk about the mid-pelvis, which is between the symphysis pubis, and we talk about the pelvic outlet, which is below the symphysis pubis. There are different pelvic types, and that's the slide that I was getting, the next one. Talk about the pelvic types. Now, the different types of pelvises and its diameter is going to influence the descent of the fetus, the progression of labor, and the type of labor. So gynecoid, and I'm just going to go so that I can tell you, and we're in the picture so that you can see it. Gynecoid, about 50% with the gynecoid, which is this one right over here. Common, normal, spontaneous vaginal deliveries. Now the android, which is the one that the boys have, that's a heart shape. Okay, very common in men, and if women are going to deliver, it's hard to go through the birth canal, so there's an increased use of forceps to get these babies out and vacuum. Okay, usually the usual mode of birth is going to be a C-section. Okay, we're not going to struggle like this. We're not going to do a vaginal delivery. Most likely, the usual mode is going to be a C-section. And then you've got the platyploid right over here, so you see that it's not ideal round, okay? The platyploid usually not ideally round, but mamas can still deliver vaginally. Then we have the anthropoid right over here. There's a lot of space over here, as you could see, so the babies are what we call sunny side up. We're going to talk about the baby's positions in a minute. Sunny side up. So this is very common for OP position, occiput posterior, or a non-spontaneous vaginal delivery. So they're really sunny side up, and we're going to talk about that in a minute. Then we talk about the station. Okay, so that you can see the baby coming down into that canal. Okay, the pelvic inlet. See the baby coming into the pelvic inlet. And this is when we do a sterile vaginal exam. Okay, this is what we're going to feel to see. We get the ischial spines, we see where the baby's head is at, And we know if we're ready for delivery or not. If the baby's descending down at 0 station, the baby's going to be engaged. If you are above, you're at a negative. If you are below, you're at a positive, which means good. Baby's into the pelvic inlet and it's making its way down. Positives are good because once you go through the 0 canal, it's a point of no return. Okay, we know that the positives, we know that the baby's coming down. Now in the hospital setting, we do, I don't know why you always insist on doing this. We do 1, 2, 3, so 3, 1, 2, 3 negative, 0, or 1, 2, 3 positives. Sometimes you'll see it as a 1, -1, or floating. If it's the baby's head is way up, it will be considered floating if you can't really feel it with your fingers. But once it gets to 0 station, that means the baby is engaged. Okay, and that is a relationship of the presenting part to the ischial spine of the cervix, and it's obviously measured in centimeters. Okay, so one of the few times you're going to hear station is here in OB. And we're going to talk, since we're talking about the passenger and how the baby's going into the pelvic inlet, we're going to talk about the passenger now, refers to the fetus. The fetal head is the largest part. Fetal attitude is this right here. They're in utero, okay, they're in utero and they have this attitude, okay? That's the normal attitude. That's a flexion of the neck, the arms, and the legs, okay? That is a state of flexion, the knees to chest. That is fetal attitude, okay? Now, fetal lie, they could be laying in utero vertex, breech, or transverse, and that's why I'm going back and forth with the slide of the picture so that you can see it, okay? Vertex is head first. Okay, this is a vertex baby, head first. This is a perfect position. Left, occiput, transverse, and we'll talk about those positions in a minute. So this is perfect vertex baby, head down. Okay, now breech is all of these babies. These are buttocks first. And then transverse, there is no C-section here. Okay, babies are transverse. I'm sorry, there's no vaginal delivery here. Babies are completely transverse. Okay, so they're going to be delivered by C-section. Okay. Fetal presentation. So fetal presentation is which part of the fetus enters the vaginal canal. Okay, which part of the fetus is the one that's entering? So when you do a sterovaginal exam, which part is felt by that healthcare provider? Okay, so which part of the fetus is entering that pelvis to go into that vaginal canal? Okay, is it? That's how you get the O for occiput. Okay, because 97 to 8% of the babies are born vertex, head down. Okay, and are positioned this way. Now, if it's the head is first. Okay, cephalic presentation, that is occiput. Okay, babies head down, vertex. Breech babies, it's buttocks or the fetus first, and the presenting part would be the sacrum. So if it's head first, the presenting part is the occiput, which is the head. Okay, the head. So if it's head first, which is 97 to 8% of these babies, the presenting part is the occiput, the O for occiput. If it's breech, right over here, okay, the buttocks or the fetus first, sometimes about 3% of babies present like that. The presenting part is an S for sacrum. And if there is shoulder presentation, about 1% of them, the presenting part is the scapula, SC for scapula. Okay? So that's the fetal presentation, is which part of the fetus enters the pelvis. Okay? We talked about the vertex and we talked about occiput and we talked about 97 to 98% of babies are head first, vertex. That is because when the presenting part is the occiput, which is the head, okay, O for occiput, the presentation is noted as vertex. Okay, so you're going to see a lot of this in the patient's charts, vertex. Now, our next one on the list on the slide over here is vertex presentation. Fetal presenting part to the maternal presenting part. It is a 3-letter notation. First letter is ROL, and that is the side of the maternal pelvis. So we're going to take this slide. You have it in front of you. We're going to go and show you. Okay. So this is mom. Okay. So this is mom's left side or mom's right side. Okay. You could see the middle notation. Okay. The second letter would be right here, would be O. And that is because that's the landmark of the fetus presenting part. So O for occiput. Sometimes it's the chin. Okay, if they're a little bit more rotated, could be the mentum. S is for sacrum, if it's a breech. And SC is for scapula, which is the shoulder. So that is your second letter notation. It's either right, this is mom's right side, or it's either left, okay? So right side of mom's pelvis, okay, right side of her tummy, or the left side, okay? This is mom, left side or right side. Now, the third letter notation, if you look at it like this and you break it, you do a square like this, okay? And you do a broken up into 4 squares, okay? Like a pie, and break the pie in 4 pieces. The front is anterior and the back would be posterior. So all of this, if you touch your bellies, all of this in your front is anterior. And all of this, okay, just touch like the back area, that's where that baby's rotating back. That is going to be posterior. Okay, and then you have the right side of her and the left side of her. Okay, of mama. Right side, okay, and the left side. Okay, now, if the baby is completely transverse, completely sideways like this, and that spine is right on mom's side, that is transverse position. Okay, anything that's from that side, okay, from the sides forward is anterior, just like these babies are, okay? From this landmark forward is anterior. And from the transverse back, just like this, where these babies are at, okay, transverse back is posterior, okay? They rotate, and how we do the landmark is according to their spine, okay? Their spine is right on the side of the transverse. If the spine is rotated back is posterior. If that spine is rotated forward is anterior. And how we notice that in a sterovaginal exam, the way that we feel the fontanelles, okay? Because we could do this on ultrasound, but when they come into the labor room and they're in labor, we want to get an idea if that baby has moved or not from the last ultrasound. We can feel the fontanelles, and the way the fontanelles are, it's a way that we know if they are rotating or not, okay? So the third letter is a landmark of the presenting part to the front or back side of the pelvis. A for anterior, P for posterior, and T for transverse. Okay. We'll go back to the slide. Okay. Engagement, that is the largest diameter of the presenting part fixed in the pelvic inlet at 0 station. So this is where we go back to the station. And that's when I said when baby is at 0 station, the baby is engaged. It's a point of no return from 0 station and out to the positive. Okay, they've already been through, the head has been through that birth canal, that pelvis. Okay. So we still talk about the passenger. Okay. We've got here, now we're going to talk about the powers, because if we don't have contractions, we're not going to have that vaginal delivery. Okay, we need to have those contractions going. So how do we measure? So this is what's happening during a contraction, okay? This is what's happening, relax, and then of course, this is the uterus during a contraction.